I'd like to welcome everybody to today's presentation on NBCC Code of Ethics 2023. This is part 3 of, I know, brace yourself, 8. But we are going step by step through or point by point, through the NBCC Code of Ethics that they released the revised version in 2023. Today, we're talking about boundary extensions, harassment, abandonment, confidentiality, informed consent, and appropriateness. Now, a lot of these, you may be kind of scratching your head going, this is pretty straightforward stuff. But is it? Boundary extensions. We talked about boundary violations and dual relationships at the end of part 2. But the American Counseling Association also talks about boundary extensions. And I know ACA is different than NBCC, but I think it's really important that we be cognizant of the code of ethics and how they may differ. And if you are a professional counselor or a licensed mental health counselor, in general, you are also held to account for the ACA Code of Ethics. Anyhow, ACA Code of Ethics talks about boundary extensions. It says counselors consider the risks and benefits of extending current counseling relationships beyond conventional parameters. Now, this isn't a dual relationship. It can get a little muddy, which is why we're talking about it. When extending boundaries, counselors take appropriate professional precautions such as informed consent, consultation, supervision, and documentation to ensure that judgment is not impaired and no harm occurs. So what are these boundary extensions? It's doing something different than having your typical 1-hour face-to-face meeting, okay? It could be going to a client's formal ceremony, whether it's a wedding or commitment ceremony or graduation, purchasing a service or product provided by a client except in unrestricted bartering, visiting a client's ill family member in the hospital, visiting a client in the hospital. Now remember, in order to provide services in the hospital, you have to have privileges at that hospital. But theoretically, you might choose to visit a client in the hospital. I'll get back to that in a minute. Going to a funeral of a client's family member and accompanying a client to an appointment, or when learning to ride the bus or do some other skill that they need to learn how to do, but they're apprehensive about. So what harm could occur? If you are attending a client's formal ceremony, whether it's a wedding or commitment ceremony or graduation, especially a wedding or commitment ceremony, you're kind of going to be there and people are going to be like, well, how do you know so-and-so? So there are potential breaches of confidentiality that the person needs to be aware of. It's also important to recognize that during some of these ceremonies, people may become, or prior to some of these ceremonies, people may become kind of emotional, and setting clear boundaries about, I am not here to provide you therapy before you walk down the aisle. I am here to support you in this process. What other harm could occur by attending some of these commitment ceremonies or graduation? And, I'm asking you, I'm not, this isn't necessarily rhetorical. So again, I want you to think, if you have a lot of clients and that are of a particular age range, for example, maybe you're seeing high school seniors or you're seeing people who are in college, and you go to their graduation, then if you go to one person's graduation, other clients might hear about it and expect you to go to their graduation or feel very hurt if you don't go to their graduation. Same thing about commitment ceremonies, maybe birthday parties. I can't think of other things, but the big ones tend to be wedding or commitment ceremonies and graduation. So you want to think about how that's going to impact the individual. Make sure you sign an informed consent before you go, if there is any chance, which there is, of violating confidentiality. Now, obviously, you're not going to talk about their business at this ceremony, but merely being there as, clinician so-and-so confirms or may hint to people that, hey, this person's in therapy. And if they don't want people to know that, then they probably ought to not have you come. Purchasing a service or product provided by a client. And we talked about bartering last week. And NBCC has relaxed their guidelines on bartering. But it's important to also recognize how harm could be inflicted if you purchase a service or product. And we talked about this a lot with bartering, so I'm not going to belabor it today. But if you don't like the product, if you want to return the product, if you are unhappy with somebody's service, then because you have a power position, I know we try not to, but we do, the person may feel rejected. They may feel bad about themselves. They may feel incompetent, or, I don't know how they would feel. It's up to talking with them about that. But it is important. And when we're talking about bartering, we talked about having another person, like your office manager, assessing the quality of the work. If you're having somebody come in and do your landscaping outside of your office in exchange for services, if that's something that you're doing, ideally have somebody who's not the therapist evaluating that person's work. Visiting a client's ill family member in the hospital. Again, we're not providing services in the hospital, but if you're doing it for one, you're probably expected to do it for all. And this is another place, and we talked about dual relationships last time, where pastors may have more difficulty, because in general, clergy, pastors, whatever label you want to put on it, they're sort of expected to visit people in the hospital. For counselors, they're not. And so you've got to define, what role do I have when I am going to visit this person? And if you are also their pastor, what do you need to do as far as confidentiality is concerned, etc. So that can get really sticky if you are also their pastor, where it's expected you show up. But if you're also their clinician, where you might accidentally violate confidentiality, or you might set a precedent that you don't want to uphold with every single client, then, there's that. You may choose to visit your client in the hospital. I had one client who had a really bad attack of pancreatitis. And he was to the point where they were starting to talk about doing some radical surgery because his pancreas was in such bad shape. I went to visit him in the hospital just to check in, see how he was doing, provide some moral support. It wasn't a therapeutic thing. I called ahead of time. I talked to him on the phone. I said, do you want me to come out? He said, yes. So I went out and I introduced myself. I was, introduced myself just as by name, not as so-and-so's clinician. Going to a funeral of a client's family member. Again, this is another one of those that can get sticky if you are also serving them as a clergy or pastor, or whatever you want to call it. Because again, it's often expected of clergy to provide support in these sorts of situations. It is also highly likely that people will recognize who you are or ask, how do you know, the deceased, and how are you going to answer that? If you choose to go, informed consent, make sure you're talking with your client about, how do you want me to answer that question, and consider it carefully. And then accompanying a client to an appointment or when learning to ride the bus. And the last one specifically, we used to struggle with where I worked at the Community Behavioral Health Center in Gainesville, because a lot of our clients had never ridden the bus, and it was anxiety provoking. And, you have to change buses and figure out the routes, and they would start to get really overwhelmed. And is it helpful to ride the bus with them the first time, help them figure out the route? Or is it better to help them identify somebody else, like a sponsor or a family member or a friend, who could help them do that? Do we want clients coming to us every time they're trying to do something new and needing us to walk them through it? Sometimes there are exceptions. In where I worked, we would often encourage them. It was a addiction treatment facility. We would often encourage them to have their sponsor go through it with them and ride the bus with them a few times, help them decide or figure out what they needed to do in order to prevent any relapse triggers. For example, a bus that went through the place where they used to get drugs or whatever. Generally, you're probably not going to accompany a client to an appointment. Every once in a while, it may come up if you've got someone who's pregnant and they're going in to get an ultrasound or extra testing because the OBGYN thinks something may be wrong with the baby. Is that something that you might go with them to? I don't know. You really have to talk about the relationship with your client and who else they have to support them. But think to yourself and consult with colleagues. If I do this, remember the ABCDEs, you're going to assess the issue and examine the benefits and consequences of all your potential options. All right, so that's boundary extensions. It's a little bit, it's kind of like dual relationships light. You're not engaging in a dual relationship, but you're doing something outside of the norm with one client that may set a precedent with other clients. And what kind of harm can that do? It may start creating dependency with a client. What kind of harm could that do? It could... there are a lot of it coulds, and it's important to brainstorm it and weigh the costs and benefits or whatever. And also make sure that the client is aware of the benefits and drawbacks to you accompanying them there. So they're aware of your mental process. You're not just saying no because you don't like them or whatever. If you may even have an agency policy that says under no circumstances, blah, blah, blah. And obviously, you need to pay attention to agency policies. In terms of harassment, counselors will not engage in any type of harassing behavior toward clients, which is defined as any verbal, nonverbal, electronic, or physical act that is known or reasonably understood to be unwelcome, or that are of a severity that would reasonably be perceived as harassment. Nonverbal. For example, ogling a client. Hopefully you're not going to do that, but that could be construed as harassment. Shooting them like dirty looks. That could be construed as harassment, potentially. Verbal, I think most of us are aware of what verbal looks like. Electronic, if you are sending them 2, 3, 5 emails a day demanding payment or even checking up on them, quote unquote. There's some unhealthy boundaries going on there, and that could be perceived as harassment. If the client no-shows and you start spamming them electronically, that could also be perceived as harassment. So at a certain point, and this should be covered in your informed consent, at a certain point, the client should know if I no show, no call, and I don't respond to an email, if that's how your practice does it, then I will get a letter. And if I don't respond to the letter, then I may get a discharge notice with referrals. Another example of harassment would be, please don't do this, showing up the client's work to collect a past due bill or follow up after a no-show. Showing up at the client's work to, sorry, I misspelled no-show, but showing up at the client's work to do a, quote, well-being check, number one, could violate confidentiality. Number two, could be construed as invasive. They want to keep that part of their life separate from their work. Counselors will take proactive measures to avoid interruptions of counseling services due to illness, vacations, job changes, or unforeseen circumstances such as natural disasters. Thinking about some unforeseen circumstances, and I have an entire class on disaster planning as an ethical issue, because we do need to make sure this happens. Think about after, we'll say Hurricane Katrina. So that's one that I went through. And there was a period there where people were not able to get to their treatment appointments. And this was before telehealth was big, but there was also a significant period where a lot of people were out without power and without internet. So even thinking telehealth probably wasn't going to happen. We need to make sure that in any event, and that's a lot of things, that if a client has been seeing you regularly, that they are able to continue receiving regular services. They're not just dropped because, we're going to be closed for the next 6 weeks. We had another issue at one of the clinics that I worked at where a pipe burst and the entire building flooded. And we weren't seeing anybody there for 6 weeks because they had to do all kinds of remediation and pipe work and everything else. So what do you do in that case? How can you, for your organization as well as for your clients, make sure that you can continue to provide and bill for services? Having a memorandum of understanding with another agency or with another practitioner that you can use their office. In private practice, it's a lot easier now that we have the day offices like Regis and some of those others. It's expensive, no doubt, but it does prevent client abandonment. So you still can see them virtually. If, again, back then we didn't have the ability to use virtual services when that pipe broke. But now we can say, all right, well, I can't see you in person in the office right now. I can see you virtually. The less ideal option for a lot of reasons is doing a home visit. Now, there are safety issues with home visits. It takes a whole lot more time to do home visits because you've got to drive there to your appointment, see them, drive to your next appointment. You're not going to get your 30 billables per week if you're doing that. But there needs to be a plan that's in place. If you are working with clients that are on medication, even if you're not prescribing that medication, it's really important to make sure that they have a plan for accessing that medication in the event of a problem. I know every time Florida has a state of emergency declared, I get an email because I'm licensed in Florida that lets me know that the governor has approved like additional refills for people on their medication because of the impending emergency. We also want to pay attention to illness. I mean, heaven forbid you should have a heart attack and have to go in the hospital for a week and then recover, where you're not going to be coming back. Or when I had my children, both of my children were micropreemies. My son was more micro than my daughter. So after I had him, I was spending a lot of time at the hospital, and I had to transfer my caseload. Now, again, I was working at a behavioral health agency, so there were people I could transfer to. But if you're in private practice, what are you going to do? You want to make sure that you have a backup. When you change jobs, now if you get fired, you're probably not going to have the option to discontinue with the client. One of the big complaints that I hear in many community behavioral health agencies is every month I've got a new therapist and I can't establish rapport with anybody, and I feel abandoned because I just got going good with this person and they're gone. Ideally, you're going to, if you know you're going to leave, you're in that 2-week notice phase, you're going to let your clients know that you're leaving, develop a reassessment of their progress, where they're at, what they're working on. That way, they know that all the information needed is going to this new therapist. You can also process the grief and the loss issues and the feelings of abandonment that come with it to prevent adding more problems to people that we're already seeing. Other unforeseen circumstances. I already talked about a pipe burst. I talked about natural disasters, fires, hurricanes, tornadoes, something that destroys the building or makes it impossible for you to see clients face to face. If you're in residential settings, this is super important too. If a pipe bursts and you can't stay in the building, where y'all gonna go? If you don't plan for unforeseen circumstances, if you don't plan for interruptions, because life happens, interruptions happen, then the clients are often left feeling abandoned. They may develop resentments. They may be in a crucial place in their treatment, and then all of a sudden you disappear for 2 or 3 weeks or more, and they feel hopeless and helpless. It's like, well, that didn't do any good. And they may start backsliding or relapsing, whatever you want to call it. So thinking about other things that might cause a client to feel abandoned. And talking about that with your agency. Remember, I said at the beginning, it's not necessarily always what you do. It could be your agency policies. If your agency has a habit of transferring people around every 6 months, probably not good for continuity of care. And determining what's going to be the best measure in order to provide a trauma-informed environment where the client feels, guess what, safe and empowered. Are we giving them a heads up? Are we processing these issues with them? Are we empowering them to choose their next therapist? Maybe they don't like the one that was just stuck in your position. Do they know that they're able to request a different therapist? Counselors shall prevent the harm that may occur if clients are unable to access professional assistance by providing the client with documentation about working agreements with other professionals or local emergency service agencies. These are your MOUs that can respond to a client in a mental health crisis. Now, we've been talking about extended absences on the last slide, but it's also important to remember if you've got a client who, well, it doesn't matter if they are in crisis when you're seeing them. If you are working with someone and outside of your session hour, they go into crisis, they may expect that you're going to be there to help them with it. They may start calling your office going, somebody's got to answer my call. If you don't have a answering service and a backup clinician, somebody on call, then it's important to make sure that they know how to access the local crisis response hotline, that they know how to access 911 in the event of an emergency. The process for continuation of services in the event of a service interruption or the clinician's death also needs to be made explicit. And we don't like to talk about this, but it is important. If we have a hurricane and the entire building gets flooded and we shut down for 3 months, or we have another pandemic and we're not seeing clients in person over the next month, what is the process? What do I do? I'm supposed to be at your office next Wednesday at 3:00. How do I see a therapist? What do I do? Making sure they know how to contact your agency, how to access telehealth if that's what you're using, and what the process is. If you, again, heaven forbid, pass away, making sure the clients know that, oh, well, this person's not here anymore, or I'm out of luck, that there is a transition plan that you have prepared. And I know we don't like to think about those things, but unfortunately it happens. And like I mentioned with my kids, with my son, I wasn't due for 3 more months. And all of a sudden he was there. So I didn't have lead time to prepare my clients. Now, of course, they could see I was as big as a house, but obviously they weren't expecting me to leave when I did. Counselors shall create and follow written procedures regarding client confidentiality rules and the handling of client records in the event of the counselor's death, incapacitation, unforeseen and lengthy interruption of services, and end of employment. You've been seeing a caseload at this clinic for 2 years. You have an active caseload. And for some reason, whatever that reason is, you are not going to be around for multiple weeks, months, or maybe ever again. How do people access your electronic medical record in order to maintain continuity of care? How do people communicate with your clients to say, hey, I am the new Sally Sue, and I'm taking over her caseload because she's gone for a while or whatever. A lot of people don't think about that, especially in private practice. We go to great lengths to have encrypted hard drives and double encryption and follow all the HIPAA, high-tech, CFR 42 Part 2 rules. But then in the event that we can't actually log on ourselves, how do people access those records? And one of the things I talk about in the disaster preparedness video is having your username and password written down somewhere and kept in a safe deposit box. Not identifying on that paper what the username and password is to, but just having it there and then having your replacement or your office manager able to access that in an emergency and whatever the procedures are for having to access somebody else's safe deposit box. But that's one of the things or one of the strategies that you may be able to use. Technology has come a long way in the past 5 years, so I'm sure there are other strategies you can use to make sure that people, the person that is identified as your backup, is able to access the electronic medical records. Confidentiality procedures shall explain how client confidentiality and records are maintained. Where do you keep them? Do you still keep them on paper? How long do you keep them in the office before they go into storage? How do you make sure that somebody doesn't log on as you who's not you? How do you make sure that people don't see things that they're not supposed to because you didn't lock your computer when you left? And that's a big one in especially community behavioral health agencies, as well as people who are working from home. It's not uncommon, unfortunately, for people to be seeing a client and be making notes while they're seeing the client, and or putting things in their electronic health record and then get up to go make dinner. And so they're going to be away from the computer for a period of time and then have somebody else walk in and see what's on their screen. It's a confidentiality violation. We need to ensure that backup counselors can access the clinical records. We already talked about that. And the procedure should identify those professionals who will assist clients in locating other professional mental health providers and ensuring the appropriate transfer of records. If you leave a job for whatever reason, and the client will assume is assigned a new therapist, and they're like, no, I'm done. My therapists have changed every month. I'm done with this agency. I'm going somewhere else. How are their records effectively transferred to their new provider? Counselors shall protect against unauthorized access to confidential client information in all formats. This can be written chicken scratch notes, which I do a lot. What do you do with those notes when you're finished with the session? Shred them, making sure you've got that shredder that does it, crisscross in 6 different ways, so it can't be put back together. That's one. Making sure that you have full disk encryption on the computers that you're using. Making sure that if you print, you recognize that your printer stores that information and needs to also be secured. You can't have a printer in an open area. Using cloud services. Obviously, if you're doing that, you need to have a business associate agreement with them to make sure that they are doing their part to uphold HIPAA and high-tech regulations. I already mentioned printers, but another thing with printers, even if, it doesn't have a memory, which I think all of them do now, even if you've gone to great lengths to protect that and it's in the staff lobby or break room and staff have to have a key to get in there, okay, that's great. But if we have multiple staff going in and out of there and you print something off, who's going to see it? It's probably not just you. I remember getting stuff off the printer where I used to work, and I'd have to sort through the paper and figure out, okay, this is mine, not mine, mine, not mine, and put that up. Now, would I read it? No, but I had to see enough in order to determine whether it was mine or not mine. Additionally, if non-clinicians have access to that same break room and that same printer, then they may be seeing information like progress notes or something or a letter that you're writing to the probation officer or judge, whatever you're printing, that they're really not supposed to be seeing. Written notes. Again, how do you protect your written notes? And how do you have a backup if your office has a fire and you're still old-fashioned paper and pencil or paper and pen notes? Those are going to go up in flames if they are not in a fireproof safe. That's the first step that most clinicians can take, is get one of those big fireproof safes, the stand-up ones, and keep your files in there. I know there are a lot of clinics and agencies that still use some level of paper, but most people have transitioned over to an electronic health record. All right, well, I know I'm going way down into the weeds on this disaster preparedness, but again, we've all had situations where our hard drive is crapped out. Where are you backing up your notes to? And how are you, and as well as your assessments and everything else, and how are you making sure that you've got redundant backups going? One agency that I'm familiar with did have redundant backups. They were very proud of themselves, but their server that hosted that redundant backup was in the same building as all of their other computers. And when the building flooded, it was the backup server was fried, as well as the original computers that had the data on it. So that was a bad thing. You want to make sure it's an off-site backup, or somehow that backup is protected against fire, water damage, and hackers. I mean, we've got all of those, the ransomware stuff that comes out. You could have a computer that just gets hit by ransomware. If you do, how are you going to protect against that? How are you going to reclaim your files without having to pay $1 million in ransomware or to that ransom thing? Overhearing telephone calls. This is another one that is common both in home clinicians that work from their own home, but also in clinicians that work in facilities. If they're on the phone with somebody, they've got the door open, or even if they have the door closed, if they don't have a good white noise machine going, other people may be able to hear that phone call and identify what's going on. When I worked in residential, we had offices. We had nice solid doors, but there was a gap that was about an inch big underneath each of the doors. So when people would talk, you could hear everything that was being said, and the walls had like no insulation. So you could hear through the walls as well. And if a client was in John's office and I was talking to them in my office, then the client in John's office was hearing everything that was being said, again, unless I was using a good white noise machine. Even good white noise machines can fail to do their job. Trying to protect people's confidentiality when they're in your office is really important. Counselors will ensure all other persons with access to confidential information understand HIPAA and CFR 42 Part 2. HIPAA requires business associate agreements with anybody who's going to have access to that record besides you, as well as all kinds of other stuff. HIPAA is long. That's why we have 3-hour classes on it. CFR 42 Part 2 protects people who are receiving substance abuse services from being prosecuted or having criminal charges or other issues come up as a result of them seeking treatment and admitting, hey, I've been using cocaine like nobody's business. Now, not everybody is required to adhere to CFR 42 Part 2. These are mainly agencies that accept Medicare and Medicaid. But it is important to recognize that you may be required to do some different things. And CFR 42 Part 2 was just updated. And they're releasing they just released the updates last month. And there were a few somewhat notable changes, but one of the things was they recognized that just like progress notes, your mental health progress notes require a separate release of information, you can also voluntarily create a different note that addresses the substance abuse issues. And those are called substance abuse counseling notes. And they require yet another court order to be released. So there's a lot of stuff. If you're working with people who have substance abuse issues, there's a lot of stuff to be aware of in addition to our standard HIPAA and high-tech in CFR 42 Part 2. Oh, and with business associate agreements, it is not sufficient for somebody to say, yeah, we follow those. You need to have a copy of a signed business associate agreement from every entity with whom you share information in your possession. Having it on the website, not enough. It needs to be signed and dated and in your possession. We do need to make sure that our front desk staff is familiar with all of the requirements. I mean, we still, to this day, when I go to the doctor, people will call me, come out and call me by my first and last name, which, I'm at the doctor's office, everybody else is there, I don't really care. But it can feel intrusive to people. People will have sign-in sheets where you do have to sign in your first and last name, and they don't cover them up. That's a HIPAA violation, actually. So how are you handling sign-ins, check-ins, and, getting people from the waiting room? Making sure the front desk staff doesn't announce to the entire waiting room, well, Mr. Smith, your insurance, blah, blah, blah. That again can be a breach of confidentiality. How do they handle that? And getting those little screens that you can put over your computer monitor so people can't read your computer monitor from the side is also super important, because there are a lot of nosy Nellies out there who want to see, what was the last person in here for, or whatever. So we want to make sure that we're doing our best to safeguard client confidentiality. Counselors shall provide the client with confidentiality procedures and will provide an opportunity for the client to discuss concerns regarding the process as it pertains to their record. If they are concerned about who you're sharing it with, etc. We're going to talk to them about reasons we would breach confidentiality. We are going to talk to them about informed consent. We're going to talk to them about releases of information. Counselors working independently will retain and protect client records as directed by state or federal law. Counselors will dispose of records in a manner that protects client confidentiality, but only after the holding time has passed. In a lot of states, that's 7 years, but it could be more. Counselors shall make efforts to inform clients and former clients of the court-ordered release of confidential client information prior to such release in a prompt and timely manner. If you get subpoenaed to release information from a client's record and it's a subpoena with a court order from a judge, you got to release it. Ideally, you try to call up Jim Bob and say, hey, just so you know, and let the client know what you're releasing, what you have to release, and so they don't wonder, well, did they get all this stuff, or did they get my progress notes or my assessment or my drug screens? What's going to them? What do I need to be prepared for? If the client seeks to prevent the release, the counselor may request the court withdraw any order to release confidential information due to the potential harm to the client or counseling relationship. Obviously, when at all possible, we're going to fight this a little bit to avoid exposing the client to feeling vulnerable, exposing the client's personal information. My experience has been, once it gets to the point that a court has signed off on it, it's very unlikely that they're going to change their mind. But we can try, and we can document it in the notes. We can advocate, one of those ethical principles, we can advocate for our clients. When ordered to disclose confidential client information by a court or governmental agency, counselors will release only that information required by the court and document the disclosure. You're going to have a copy of the court order. You're going to identify specifically what information was released in that particular disclosure incident. Counselors work to provide reasonable, timely access to the content of the client's own clinical records when requested. Now, this created a lot of consternation when they first introduced it a decade or so ago, maybe 2 decades now. But it's important. Counselors will provide an opportunity for the client to discuss the content of their record. If there's a reasonable basis to believe that the direct review of the record will cause the client harm, the counselor will discuss the request and possible effects. This is why, people, when you are writing your notes, when you're writing your assessment, your comprehensive summary or integrative summary, whatever you call it where you're at, you need to use objective language. The client is diagnosed with major depressive disorder as evidenced by. The client has been failing to make progress in treatment as evidenced by. You're not using what can be considered pejorative terms like the client is being resistant to treatment. Well, resistance is a behavior that is communication. What you're talking about is the client is not complying or not making progress as evidenced by. That way the client can read it and go, yeah, you're right, I wasn't doing that. Or they can argue about it and say, I did that. Where were you? If you don't think that they can handle reading their documentation, then you want to discuss it with them. And again, if you've written your notes ethically, reasonably, and objectively, nothing in the record really should be a surprise to the clients. Counselors will document each client record request in the client's records. When might this be appropriate for them to request their records? Anytime they darn well please, quite honestly. And how can you ensure that the client reading their records will not cause undue harm? Use objective, non-jargony documentation. Make sure you support any judgment you make. For example, your judgment to diagnose with major depressive disorder, not an ethical judgment. Any statement you make is supported by facts. Facts in this context at this time, going back to straight cognitive behavioral. Being authentic with the client. When you are in session, when you're doing notes, if you're going to put something in the notes like Jim Bob is non-compliant with treatment, I'm going to talk about that with Jim Bob before I put it in the notes. I'm going to say, I'm having some concerns about your progress. Let's talk about what's going on. I'm being authentic. So again, if Jim Bob looks at his record, it's not going to be a surprise. He's not going to feel like I was talking bad about him behind his back. Thinking again about harm. How might people be harmed, or how might it trigger prior traumas if they're caught unawares? I know I hate it when I go to the doctor's office and everything, and they have these files and they're just tapping on the keyboard. I have no idea what they're typing in. I'm trusting that they're typing in accurate stuff and they're not saying, oh, she's a complete hypochondriac or something. But I don't like that. Empowering clients also can mean being an open book, letting them look at, if you do your assessment, I always tell my clients when I'm finished, if you want to read your assessment, we'll go through it together. We can talk about what my observations were. Same thing with progress notes. I usually do progress notes with the client, and in the last 5 to 7 minutes of the session. So we have a session for 45, 50 minutes, and then we work together to construct the progress notes, reviewing what treatment plan goals we addressed, progress that they had, successes, challenges, referrals, and then I give them a copy. Why do I give them a copy? Well, they can destroy it if they want, but it also helps them track their progress and objectively monitor it. In the case of minors, counselors may limit access to the minor client or responsible guardian if there's compelling evidence that other access may cause harm. Thinking again, when might this be appropriate to limit a minor's access to their file? When might it be appropriate to limit the guardian's access to the file? And that one you can see a little bit easier, where if the minor has been telling you stuff in session that they don't want their parents to know, you have this whole ethical, legal issue of maintaining fidelity to the promises you made the client, but also maintaining fidelity to the legal guardians. And this is an issue of dual loyalty, if you want to think about it that way, because you're trying to be loyal to your patient, but you also need to adhere to certain things in order to legally treat the patient and ethically work with the family. With an informed consent, either prior to or during the initial session, counselors inform clients of the purposes, goals, procedures, limitations, potential risks, and benefits of services. This is really important, and I think it rarely happens, quite honestly. A lot of times people are given an informed consent that says, I am consenting to treatment with Dr. Dawn-Elise Snipes at blah, blah, blah address. I recognize the fee for service is this. I recognize these are the procedures for emergency, and I agree to blah, blah. That's not an informed consent. That is not an ethical informed consent. We need to talk with them about, okay, we're going to use, in this treatment, I think that CBT and EMDR together would be really effective for you to achieve these particular goals. This is what these things look like. These are the limitations of CBT and EMDR. These are the potential risks and potential benefits. We also, and I didn't put it up there, we need to let them know about alternatives. If they don't want to do CBT and EMDR, all right, what are alternative treatments that may be available to them? We also, in the informed consent, according to the ACA Code of Ethics, need to make sure that they are aware of our qualifications, our credentials, and our relevant experience, letting them know that we've treated major depressive disorder before, or eating disorders or something, and what our umbrella process is. Obviously, we're going to individualize treatment. We need to inform clients in the informed consent of their rights and responsibilities, including billing arrangements and collection procedures in the event of non-payment, confidentiality and its limitations when you might have to be a mandatory reporter or breach confidentiality, and service termination policies as appropriate to the counseling setting. When you're done with services, what's that going to look like? The professional information will be provided to the client in verbal and written forms. You can't just hand them a form and say, read this and sign it. You need to talk it over with them. With a signed confirmation of understanding of the form, so they're agreeing they understand what you've talked about, what's on the form, and documentation of any related client concerns prior to the beginning of therapy. Examples of concerns could be the client was told about your background and blah, 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 and they don't want to see you. Maybe you're doing an assessment and then you're going to refer to a therapist, and the client says, I will only see a therapist that meets this description. Or I will need to be able to, if you're talking about group therapy and you tell them what it's going to look like, maybe they have a bad back and they can't sit for an hour and a half. So they're going to say, I will need to be able to stand up during session. Some clients, even if it's part of the program, will say, I'm not taking medication. No. Or I will not. This part of the program is offensive to me in some way. I will not do it. Instead, I will. Counselors shall discuss the appropriateness of counseling services offered with the prospective clients and document that they've had this discussion. This is why I think this particular approach or setting, like residential or outpatient, is appropriate for you at this time. If there's reasonable cause to believe a client will not benefit from counseling services offered, counselors will explore alternative forms of treatment and or discuss and or facilitate a referral to another provider. If somebody's going through the same program for a third, fourth, fifth time, it may not be appropriate to have them go back through it again. Maybe that program is not meeting their needs for some reason, and a different program might be more appropriate. If the person is intoxicated or in an active psychotic episode, we need to consider what referrals would be appropriate. I am not going to put someone who meets either one of those criteria in a therapy group until they are stabilized. If they have certain biomedical conditions, you don't want people with heart conditions going out and doing ropes courses without having full consent and medical clearance. If they have concurrent mental health and substance abuse conditions, you want to consider how are they going to be appropriate for outpatient, or how are they going to be appropriate for group in the referrals that you're making. You need to consider their readiness for change. Ideally, you don't want to take somebody who is in pre-contemplation, they're being court-ordered, and put them in a therapy group where people are in the action stage of change, because it can be extremely disruptive. You want to consider their relapse prevention potential and their recovery environment on the outside. So if you're recommending outpatient, is that an appropriate recommendation for someone who is living in a household where their significant other is regularly shooting up heroin? Probably not a good placement. We talked today about boundary extensions, which are doing things in session that are not your standard hour therapy. We talked about harassment, preventing abandonment, especially in the event of extended interruptions. We talked about confidentiality, informed consent, and evaluating the appropriateness for treatment. When we are making referrals, when we are choosing tests, and we're talking about that tomorrow, Saturday, we need to make sure that they're appropriate in order to prevent doing harm, in order to make sure that we are faithfully executing our job as a clinician to advocate for and the client and help them achieve their highest quality of life as they define it. Are there any questions? Sammy, that's great. I'm glad that you read your records after each visit, and I'm glad your clinicians allow you to read your records after each visit for that exact purpose. So you can make sure that you're both on the same page, literally. And again, if you need more live hours, the next 3 Saturdays, I'm going to be doing sort of live webinar marathons. This Saturday is a 5-hour ethics. It's 5 hours because that's what Georgia requires. So for people who weren't able to attend these last 3 hours, we're going to do a 5-hour ethics marathon. Then we're going to do one on the neuroscience of mental health and addressing personality disorders. Actually, Adriana, the Saturday is not at 12 p.m. Eastern Daylight Time. It's at dark 30. I believe it starts at 9 a.m. Eastern Standard Time. So bring your coffee. I understand. And actually, just so you're aware, the live marathon sessions on the upcoming Saturdays, we're actually going to use the video, audio, video, Zoom type thing that's within our learning management system. We're not going to be doing it on YouTube. That way we can have more interaction, which I like. I like interaction and less delay between what you say and what I receive. So it's humane. Quite honestly, so it's humane. Attending a wedding ceremony or graduation, for example, if you've been doing premarital and couples counseling with a couple and they're getting married and they invite you to come, when might that be appropriate? Now, some people will say, like you're saying, some people will say, well, that's never appropriate. Other people feel differently. And that's where ethics differs from laws and rules, where they say you can and you can't. Ethics is a judgment call based on what is the benefit to the client and the potential harm that it could cause. And also, what is the benefit to you and the potential harm that it could cause? In terms of not acting as their therapist, we were not doing therapy. I was there to check in, provide a little bit of support, hey, thinking of you. I will, I'll be here when you get out. And, but I wasn't providing therapy. And it's very important that if you're in a hospital that you don't provide therapy. It's I guess you could call it more of a case management sort of thing if you want to label it something. All right, everybody, have a wonderful day. Thank you for the questions, and I will see you, if not Saturday, next Wednesday.